Security of health, LabCoP. Development of the labs, LabCoP. Knowledge exchange, LabCoP. Thumbs up, LabCoP International. Dates 23rd, LabCoP. Promoting adherence, LabCoP. Monitoring the patient, LabCoP. Thumbs up, LabCoP International. Any African country can join LabCoP International by submitting a letter of support from the Ministry of Health, identifying a multidisciplinary team that includes laboratorians, clinicians, program managers, and civil society. Thumbs up, LabCoP International.
So it's at the top of the hour, colleagues, and welcome to our mid-July 2022 eco session. My name is Francis Ochen from the African Society for Laboratory Medicine, and I'm delighted to be your host today. As usual, our session will run for 1 hour, and we'll take one presentation and some quick panelist comments, and then we'll dive into the questions and answers. We implore you to join the discussion through our chat room. Post your comments, questions, and alternative views on the discussion that we'll be having today. We also have interpretation services. Please keep to either English or the French channel. Get off the off channel so that you can get real-time translation services depending on the language that you prefer. Today, we convene to discuss a very pertinent topic, the rapid HIV test continuous quality improvement, the famous RT-CQI. This is an initiative developed by PEPFAR and the US Center for Disease Control and Prevention in partnership with other stakeholders. And its intention is to develop capacity and assess competencies of individuals and facilities performing rapid testing and their knowledge of quality related issues. We know that quality HIV testing is critical in ensuring the achievement of the first 95 of UNAIDS 95 targets. Given the often high number of facilities that conduct rapid testing and sometimes multiple testing sites within the same facility, digital solutions have a potential to provide real-time and reliable information on progress to field staff, managers, implementers, and government agencies. In today's session, we will discuss the implementation of an innovative solution for RT-CQI program in South Africa, led by Strategic Evaluation, Advisory and Development Consulting, commonly referred to as the SAID. And in doing this, we have one presenter and two panelists. Our presenter for the day is Dr. Tim Tucker. Dr. Tim is a clinical virologist and is an adjunct professor at the University of Cape Town School of Public Health. Tim is also the founder and chief executive officer of SEED Consulting. He is the inaugural director of South African AIDS Vaccine Initiative, and he has been a member of multiple healthcare organization boards and currently is a member of the South African Medical Research Council Board. He is also the National Health Laboratory Services Research Trust Board member and a member of the US government National National Institute of Health HIV Strategy Working Group. After Tim's presentation, we will have two panelists who will give commentaries on the presentation. The first panelist is Marco Susanna Makanya, and Marco is a molecular biologist with a background in quality management system. She's currently a senior public health specialist and a lab advisor with CDC South Africa. And she has served as the technical lead for RT-CQI with the CDC lab branch of South Africa. And our last but not the least panelist is Professor Alshale Abimiku, and she is the co-founder and executive director of the International Research Center for Excellence at the Institute of Human Virology in Nigeria. And Professor is also a professor in the Department of Medicine at the University of Maryland School of Medicine. She has established the first research lab in central Nigeria and currently works as a member of the advisory board of ASLM. Colleagues, join me in welcoming our presenter for the day, and Dr. Tim, over to you. Thank you very much.
Thank you, Francis, for that kind introduction, and it's really great to be here today. Thank you. Well, good afternoon, colleagues, and thank you very much for this opportunity to be with you today and to present on something very close to our hearts at Seed Consulting, the area of RT-CQI. And we've entitled this talk, Where Rapid Testing Quality Improvement Technical Assistance Meets Digital Transformation. I do this as CEO of Seed Consulting, as well as an adjunct professor in the School of Public Health at the University of Cape Town. I also want to acknowledge right up front that what I'm about to present can only happen with teamwork. I have in the top middle Dr. Peter Manyika, who is Deputy CEO of Seed Consulting and Head of Health Programs. There's then Lamont Newman, who is Chief Innovation Officer, and Amanda Matlala, who is Executive Director for Lab Services. And below is a photo of our senior management team at a recent retreat. And they really are the amazing people in the field who roll out these programs across the whole country. My thanks to them in advance. It's also important to note that this work cannot happen without donors, and this is not partners so much as donors. And these are the groups that over the last 5 to 7 years have provided significant funding for this part of our work. And I also want to comment on the fact that the top left, PEPFAR through the CDC, have contributed the most significant amount of awards to this RT-CQI work that we have done in the last 5 to 7 years. Seed Consulting is a niche public health consultancy established almost 18 years ago, and we have a very specific set of activities that we are involved in. We're not going to talk at all about our pharmacy health system strengthening program today, but we're going to focus more on the lab program, where we have a significant clinic lab interface program, as well as a significant point of care testing program that we will be speaking about today. But over time, we have developed very significant business analytics capabilities as well. And nowadays, almost nothing happens in our group which is not data-driven, which is about analytics, and where we have data to drive our decision-making, all of which is based on us trying to achieve the joint aims of 95, 95, 95. And so today I'm going to take you through a little bit of a journey. We've been involved in improving HIV tests and services quality for more than a dozen years. And I'm told that there will be some people on this webinar today who do not come from an HIV background or a point of care testing background. And so to ensure that everybody on the call is up to speed, there will be some of the earlier slides which give a little bit more information than I would give if it was purely a group of people that were involved in HIV testing. So please, if you are an HIV testing expert, please understand that I'm going into some detail about some of the elements to ensure that everybody's up to speed. And then I'm going to describe the move to what we in Seed are calling RT-CQI Plus, the utilization of RT-CQI as a methodology, but linking it to digital health, moving from a traditional, quite labor-intensive approach to a seamless digital platform. In that, we will be looking at some of the digitally assisted tools, the distance-based learning tools, and using this RT-CQI as a model. Please bear in mind that today we're just talking about RT-CQI, but this platform that we have can be used for other health system strengthening services as well, but we will not be talking about that today, but please bear that in mind. So why did we get involved in HIV rapid testing QI? Well, in South Africa, we started more than 12 years ago, and here's a slide that I think has come up even in an ASLM conference setting, this one being a slide from 2010, as you can see. And it was a set of slides on the analysis finding of HIV testing quality in South Africa. And what we found with this in-depth systems analysis was that if you divided up HIV testing, rapid testing, into the different sections, and on the bottom here, we did direct observations of hundreds and hundreds of HIV tests being done in facilities across all 9 provinces. And to do this properly, you can't pick and choose which elements you're going to do properly procedurally and which ones you're not. You have to ensure that you identify the patients correctly and make sure that you have that patient's folder in front of you. You need to ensure that you use the registers correctly, that you take a full history inclusive of pre-test counseling, that you do the test properly, including the incubation period, and giving the test results properly. If you need to do test 2, and you need to do it correctly before post-test counseling, whether the person is HIV negative or positive. And I give you a sense of this because what we were able to see with direct observation was that only 73% of the time was the identification of the patient done correctly, which then wraps up into, well, did you give the right result to the right patient? When doing test 1 procedurally, only about 30% of the time was the test done correctly, and the incubation period varied from a few minutes to well over the incubation period for the designated test, and so you could get false negatives and false positives. My point with this slide is that this gave us quite a shake-up when we realized how many challenges there were in South Africa for the procedurally correct rolling out of HIV testing. And this led to a lot of soul searching, and I think that soul searching was independently done in different countries and led also by different agencies, including significant effort within the African continent and within the PEPFAR systems to codify the elements of HIV testing quality. To that end, many of you will know about the stepwise process for improving the quality of HIV rapid testing, otherwise known as SPI-RT. And for those that are not involved in HIV rapid testing, these are the elements that became the central elements for understanding the quality site by site of what was going on with HIV rapid testing. And there was a personnel training component inclusive of certification. So it was not just training, but it was having certification processes as well, assessing the physical facility, safety issues, pre-test, testing, the post-testing phase, as well as external quality assessment. And when you score the facilities as per the right-hand side here, you can then get into the space where a poorly performing entry-level facility might score below 40% and have a level 0 score given to it, all the way up to level 4, where facilities are eligible for national site certification. And obviously anybody doing this kind of work needs to push as many of the facilities as possible out of the lower levels towards level 4. But this is a tool. It's not a method, it's a tool. And what then came out of that was the rapid test continuous quality improvement methodology, which used SPI-RT as a tool to really get the initiative moving forward on structured, standardized interventions. So RT-CQI is a comprehensive package of quality improvement activities, as listed over here, from guidelines and policies to the things that I've just talked about now. But ultimately, it's all about the triple 90s, which has become the triple 95s, and focusing on the fact that if you do not do the first 90 properly, in other words, if you're not able to give accurate tests to every single client who comes for testing, your whole cascade through the 90s and the 95s becomes problematic. So this test is all about the quality of the result that we give as it relates to the first 90. And so SEED then applied that RT-CQI method, and our methods, as you will see, involve the evaluation of national policies, ensuring that the infrastructures that were available nationally and regionally were appropriate and functional. We had people in the field doing baseline assessments and ongoing assessments. Multiple interventions, including training, were rolled out across the country. It became important to ensure that there were internal quality control samples available and proficiency testing, also known as EQA, in the mix, so that each facility could have these. And it was important to measure improvement. And my point here is to show that we adopted this RT-CQI as an organization, as a country, and we rolled this out in what was quite a labor-intensive way, as I will describe now. I think it's important to ask the question, and many of you on this webinar know the answer to this because you are involved in this, and this today is not so much about proving that RT-CQI as a methodology works, but just to remind ourselves that it does. And I will give you one overview of one of our projects, which was a PEPFAR CDC award, where our organization was mandated to do RT-CQI across the entire country and to work with all the provinces and the implementing partners. And to your left over here is the 27 performance, the 2018 performance. and we became involved in 2019. But what you can see in South Africa is that in 2017, the overwhelming majority of facilities were in level 2 and level 1, with very few in level 3 and none in level 4. But by the time we started to get involved, we were able to then improve it. And you can see that now level 4 became a significant group of percentage of facilities, and level 3 became the next dominant one. And by 2020 and 2021, we were able to, and I want to accentuate this, we were able to, with government, with the implementing partners, not just on our own, we're able to really get the performance overwhelmingly to level 4 across many of the organizations, and none of the facilities that were evaluated in this round were level 0 or level 1. So I think the answer to my question is yes, the methodology does work, but what we needed to do was to ensure that we kept up with the times and made sure that we were able to pivot to a more efficient way of doing things. And so what I'm going to do in this next phase is talk to you about what SEED's digitally assisted TA platform entails and how it is used in the field to ensure that RT-CQI is done in the most efficient and best way possible. I think it's important at this stage to say, well, what problem were we trying to solve within SEED? But I think that in our earlier days of working on RT-CQI, we became aware of the fact that our approaches were not precision-based. We had large numbers, far larger than per district than we have now, within which our field staff would go into the field and would have a similar methodology across the board that they would approach each facility with, and they would then roll that out. And in the age of the need to pivot towards precision public health, we realized that our approaches were not in keeping with that. Then our staff would also be in the field. Yes, they might have a laptop, but overwhelmingly the documentation was done in paper form, and that paper form would then have to be returned to the office and uploaded into electronic form, and that was inefficient. In addition to that, many of our field staff, like your field staff, are in very remote areas, and they need support, and we were not able to support them as much as we wanted to, and we wanted to pivot to that increased support. We were also, although we trained every single one of our specialist staff in what they were doing, we also became aware over time that sometimes it was not as standardized in format for the interventions as we wanted, and we wanted to pivot to something more standardized, where the reporting was not so cumbersome. So historically, in the paper-based system, our field staff would go out into the field for 4 days, and then the whole of Friday would be dedicated to reporting, whereas we needed something more efficient than that. And what we will see now is that we did do that at an organizational level in moving towards RT-CQI+. We took all of our institutional knowledge, all of our tools, all of our training resources, and converted them into state-of-the-art evaluation support and educational content. This included video lectures, tutorials, infographics, assessment apps, etc. And it's used across our entire staff system, ensuring that not only our staff use it, but recipient healthcare workers and administrators also use it. So our staff use it, other implementing partners use it, Department of Health staff use it, and it's all automated for the system of data. So we had then moved into this digitally transformed health system strengthening program, and we're able to do this. Slight repeat of 2 slides back, but 2 slides back talked about what the problems were, and this talked about what we moved to. We were able to do things at scale, high quality, standardized intervention. And importantly, because we'd standardized the training materials and the apps and the evaluations, we didn't need to have a super specialized person at every point. We could train some more generalists in the field to ensure that they could do it, supported by our super specialist managers in the head office who had direct links to them. We were also able to have far more comparable data and measurement of impact. So we now have this seamless program management platform that I'm going to describe to you. Essentially, there are 3 components that were developed. Firstly, on the top left, there were a series of SEED apps that were developed for the different program areas. and every field worker would then be trained in those apps and would be allocated to the apps relevant to their area of speciality. They then worked hand in hand with their managers on the right-hand side, and we developed a management platform that I will describe today. And thirdly, we then developed a learning management system. And we are well aware that there are multiple learning management systems around globally. Intrinsically, they're not always that innovative, but what we have on this platform is entirely innovative and comprehensive, and it is in keeping with the standardized methodology of RT-CQI+. We've also done this to ensure that all levels of staff and implementers are catered for. You will see our field staff have their apps, the managers have, the M&E staff have, and then we also have a direct feedback on a weekly basis to donors and governments. So let's start on the top left there where the arrow is pointing with the Seed Collect app. Well, we have customized apps which are used on either basic smartphones or on tablets or on laptops. And importantly, like many of your environments, many of our environments, the field staff would be working in facilities where there's no internet connection. And so these have been designed in a way where they do not require live internet connection. Everything is preloaded, including the training materials and the evaluation apps on those tablets or smartphones. And then when they have completed their work in the field and they come back to the office or they come back into cell phone tower signal where they have data, only then is it loaded up. But if they are actually at a facility where there is live internet access, it's loaded up as they do it. These apps then allow them to analyze the environment, either at baseline or on an ongoing basis, to conduct capacity building interventions, to communicate in real time with their managers, document their activities, and track progress. So this is really what it looks like. We have either on a cell phone as shown here or on a tablet. They then go into the facility and do their work, and then they would then choose this. And I'm going to show you a video, which is just for you to see what we do. So it's just a single example, so you have a sense when a field worker goes into the facility, they need to ensure that they do certain things. So I'm hoping that this will work and I'll be able to stop and start it. But then what happens is that field worker will go into the facility and choose an app. They will log the date and where they are. Some of the facilities are GPS located, or the person selects their individual facility, and then they should then pick what they are going to do. First of all, in the COVID time, we do a lot more remote work. This example is where somebody's on site and where they then choose, as you just saw there, they chose that they were going to do the IQC work on site. When they then choose that they're going to do the IQC work on site, they then have to do the evaluation of IQC. And in this case, the person has chosen that they're not going to, that there was no IQC samples, and then they have to log what they do in real time. And on this occasion, this field worker says, I think what's going to work best here is if I show the video that I have on my tablet, which is a training video on IQC. That then gets logged, and the video then is then shown to the facility at that moment. And the important thing that I want to show you here is that this field worker does not have to return to the office, report back to their manager, and then come back and show a video. They can, whether it's a supply chain management video or a safety video or an IQC video, it can be done at that time. So the evaluation is part of the intervention as well.
When stock levels are low, the facility must notify the district coordinator or the provincial coordinator.
So I'm not going to show you the whole video here. There's a 2-minute video here, and we will be submitting these. We have already submitted these slides to the ASLM, so you can have a look. But the point here is to show you the principle that our field workers are capacitated on site to be able to do this work. So let's take the next level of support, the support for the managers, which is this area on the where the blue arrow is here. We need to make sure that our managers and are communicating on an active basis with their field staff. And in addition to that, have access to comprehensive dashboards, which are live, that can do monitoring and management of the teams, and ensure that they have data and business intelligence visualizations for implementation, as well as M&E and reporting. So let me give you a couple of examples of that. This is what we call our live ticker, and every manager in the head office or wherever they are working from can see exactly that on this date on the left-hand side here, these individuals who are staff members of ours have been to the following clinics. Some of them have done RT-CQI work, others have done clinic lab interface work, and on the right-hand side, it gives a live ticker, and you can see it ticking over as these are uploaded on an hour-by-hour basis, what the staff members have been doing. But this is not this doesn't give you an ability to implement anything or design a program. This tells you where people have been and what they are doing. And so I'm going to move to give you one example. There are multiple examples, and some are at the end of my talk, where the managers are actually able to use this data to decide where to go and what to do. So our business intelligence group then automate the system so that managers have something like this. Now, I have blanked out the left-hand side because it has the names of the clinics, and I think there's some confidentiality issues there. But on this occasion, what you see is that there's a national grading for every single clinic that we work in. There's an overall score and percentage, and these are the 7 elements of SPI-RT. And what you can see is that every single clinic then has a score from 0, which is clearly a clinic that needs urgent attention due to the level 1 and the level 2s, and so on. Again, what you can see here is that when we design our quality improvement plans for each clinic, we can then see that these clinics actually have a proficiency testing, an EQA issue, and that's what's dragging down their score predominantly. In addition to that, this one over here has an EQA problem, but also has the other issues that are listed over here. And so what happens then is that with a click of a button, here's an example of where I clicked on the level 2 for this clinic over here, the field workers' notes are incorporated for each of those elements, and an automated quality improvement plan comes out. And this is where we've used our 12 years of knowledge in the field, where we can take the observations of what is wrong and convert it automatically into quality improvement plans for each and every facility, so that we don't just get a district-wide or a sub-district-wide quality improvement plan. Each and every single facility gets its own quality improvement plan, and when the field worker goes back, they are able to see exactly what needs to be done on their apps in the field. Finally, let me talk to you about the learning management system that we have in place. And you will have seen a little bit of that with that video I showed you. But the learning management system is in 3 levels. There's the traditional in-person training, there is online training, and there's on-site training. And the in-person traditional training is where we pull people together, and we still sometimes have some districts that want to pull people together into a central facility area for training, and we can do that as a standardized central training area. Secondly, we have online training. Some people want to do online training at home on their own, and others want to pull people together in their work environment and together do the online training. And the online training now is on a web portal put together by our business analytics team. You can see on the top right, you would have to log in, and we would give you a bespoke login, so we know whether you are a Ministry of Health staff member, an implementing partner, a donor, and also whether you are a manager or not, because the managers who log in then get a report which is a little bit different to the field workers. But what happens then is when you logged in, and you can see our person Max is logged in over here, and he has a series of things he needs to choose from before he gets these self-paced choices on the right-hand side that he will click, and I will just zoom in on that. There are 10 full modules and an 11th one, which is the professional ethics module. And you will see that each one is a module followed by a quiz. You can't get onto module 2 before you've passed the module 1 quiz and gone through the entire module, so you have to go through all of them. And at the end of it, well, during it, sorry, you have the video itself, as I've showed you before. The video plays through with specific learning objectives and the content. And then the person doing it needs to then have a test and pass that test before they can go on to the next module. So those are, we're very happy to talk more to you about that. I'm giving you a sort of high-level view of what is possible on the online training. And what is important then, in addition to that, is that when our staff go into the field and there are people who need to be trained, those same videos or snippets of those videos are then available in the format that I showed you just a couple of minutes ago, where the field workers who sometimes are doing other work are also then working on capacitating through the videos like I just showed you a few minutes ago. The importance here is that it's seamless, whether you're having in-person training, online training, or on-site training, you're getting the same content, and ultimately those same individuals are then able to be certified irrespective of how they get that training. Finally, what we need to do is we need to ensure that all of this data is compiled in a way where we as the implementing partner, or to the other implementing partners, or to donors and governments, get a report. And what we see here is multiple visualization. You'll see in quite a few of the visualizations I've blanked out something over here, and that's for confidentiality. But what you can see here is that there are a series of people who've done the training. Some have completed them, some still need to do more, and therefore you can focus down to individuals as to, okay, you've logged onto the system, your manager would like you to prioritize this and complete it, please, before you go on further. If you want to see by province who's completed it, you can get visualizations where each province is shown here and how many people have done it. And the different colors are because some of them are from correctional services, the prison services, some are from the Department of Health who train, some of them are district support partners, etc. And there are a myriad other visualizations that we give every single month to our partners to ensure that they know what's going on. Here we've trained a whole lot of the district support partners in this. The ones on the right-hand side might not be doing badly. There may only be 15 people on that organization that need to be trained, but at least we know how many we've trained and know how much further to go. So this is not a good on the left and bad on the right. It may be just that the people on the right, that organization is just starting. This also gives you a sense by month who's being trained, and this slide gives you a clinic lab interface in light blue and RT-CQI training in dark blue, and the learner completions by month. So not just those that are enrolled, but those who completed and therefore certified and ready to go. Importantly, also for donors and governments, we have a part of the reporting that every single Monday our business analytics team send to Corsi, who's going to be one of the respondents now, and the USAID colleagues as well, dashboards like this. So this is a Monday morning dashboard, and you can then also see it, whether it is the CDC on the top left, whether it's a CDC group or a USAID group, you can sort for those. You can sort according to the district support partner or the province or the district. Now, again, I blanked out for confidentiality reasons here. This is the district support partner on the top left and which province they work in. And you can see that some of them have some level 0 and level 1s that they need to get on with and improve that. On the right, that's a similar kind of representation of that. And on the bottom, along the bottom, you can see there's lots of different views for your donor or your government to see what's going on. Here's a visualization of the 7 domains of SPI-RT, and you can then sort according to which DSP or which province. And you can see that we're doing pretty well, but is it actually improving or is it going backwards? And so we can then give you another visualization, which shows you that it was yellow in the first year, it went outwards and outwards to show that progressively we are actually achieving what we want to achieve over here. This is a dashboard of this, which is the same Monday morning dashboard that goes to donors and governments, that shows you province by province. And I've blanked out the provinces over here and along this bottom one. But what you can see, if you're a donor, you can see that this one province just second from the right here is the one that's holding down the overall country score. And that's where we need to dedicate our efforts. And we can also see where it is that they are performing poorly. What you can also see across the entire country is that training and certification needs to be improved. And this is what, in part, this platform has been developed for, to ensure that we in South Africa, and now we are happy to now that we have got it in a form that it is stable and ready to roll, we would be happy to train and do this work across other countries as well, because you can imagine that every country that's doing RT-CQI can have these kind of visualizations. They can then focus in where that work is most needed. And so finally, to wrap up, I think it's a fair question: is HIV rapid testing continuous quality improvement still relevant? And I merely take a screen grab of the latest COP22 guidance for all PEPFAR countries, PEPFAR supported countries, where it stated improving the quality of laboratory and point of care testing for HIV is critical, but an often neglected aspect of global public health. And, you know, I think that this is important as we move towards our 90s, our 95s. We need to make sure that we are able to give the correct results, whether negative, HIV negative or HIV positive, to our clients, so that we can ensure that we do this work properly and that we are able to move forward. So we now have a greater understanding, greater precision, greater support, greater focused training, and it's scalable across the whole continent at a reduced pro rata cost. And I want to make one comment here. Its beauty is in its simplicity. We haven't made this complicated. We've made RT-CQI simpler. We've taken away the paperwork. We've offered more support to staff. We've made it digital and uploaded so you can do this in real time. And we just want to thank you for this opportunity, for being able to join you today, to talk about our platform, to talk about this move from RT-CQI to RT-CQI Plus. Our details are there. We'd love to talk to you if you're interested to talk more about it. It's been a very exciting journey. And Francis and Anafi, back to you. Thank you so much for this opportunity.
Thank you. Thank you very much, team, for a very clear presentation. You've summarized the journey of RT-CQI, linking RT-CQI to digital health, compliance summaries for some of the olden days data from South Africa, and then the central elements that you deal with when looking for competencies and also performance levels. And it is an amazing one for some of us who have supported multiple labs in implementing RT-CQI. The manual way of doing it is really laborious, and it wears down the importance of then using data, because at the end of the day, you just look for some data at the end of your 6 months or 4 months, depending on the reporting frequency, and then submit. So the routine looking at data to see where problems are becomes very difficult when collecting such data is not as easy. And I know that the colleagues who've done this really relate with my comment. Before we go to the question and answers, we will have the two panelists just make quick comments, and we'll start with Marco Susanna, just to make a quick comment on your experience with this, and based on what you've heard, what additional info you may want to share with our participants today.
Thank you very much. My name is Kosi Makanya from CDC South Africa. I'm the technical lead for RT-CQI implementation countrywide. So we work in 2,600 PEPFAR supported facilities, which are spread throughout 27 districts, and we work with various district support partners. So for me, this introduction of digital platforms and tools has made activity management easy. So this makes easy the management of both the program and the partners. And I'll just comment on, my comments will actually be focusing on the benefits that we've had so far. So if you're looking at specifically program management, it has made programming that is data-driven, which means that you maximize your value for the money, because your programming is looking specifically at the issues that have been identified. So the gaps, because we're using standardized tools and we are able to actually identify gaps and formulate specific interventions. And with this also comes the identification of the people that are well performing, so we can actually go to the high performers to get them to share best practices with the other DSPs, so that we are able to actually now transfer whatever has been working in another side to another side. This really helps in terms of making sure that we have a coordinated program in the country, and we are able to see where we're making progress, and we're able to work together where we're not making progress. It also helps to have a standardized platform for training, especially with the video-based training materials, and also with the e-learning platforms, where we can now access a lot of people without having to go to a physical training. And coming from a COVID era, we all know that virtual platforms have really helped us to move on. And it also helps in the sense that we have a standardized package, and we know that countrywide, we are all implementing the same program, we're all having the same trainings, and we're all able to come together and discuss issues together. So now, if we are looking at the partner management side now, what have been the benefits on that side? Having said that, we work with various partners in 27 districts. It's very difficult for one person to be moving around providing technical assistance countrywide. But if you've now got everything virtual and you've got a national database, you are with having a national database, we're able to look at everyone at the same time. So everyone is using the same data collection tools. Everyone is uploading to the same platform. So each district support partner does their work in their district and uploads to the same platform with a uniform tool. So we're able to then see all these tools and be able to monitor progress there. And it's very easy. The dashboards that we are given weekly makes it easy for you to see who is doing what where without having to travel to that area. And these dashboards are actually real time, because if you want to actually go in and look at what partner A is doing versus partner B, you can actually go in at the same time. So these are the few benefits that we've had. And the last one I want to talk about is demonstrating the impact. So out of all this, you can have the same tools, because we've got all the country data in one database. We're able to compare, like the example that Tim gave on the SPIRE-T. We're able to look at the SPIRE-T over the years and look at the data and be able to see what is going on, who is progressing, where are we doing fine. And these also show over time the impact. And with that, you can also use the same tools to be able to now write scientific papers, because now you've got all that data that you can follow up over the year, and you can then have a good material for scientific paper writing. So with that in mind, one would actually ask, is digital transformation the future for technical assistance? And from my side, I would say yes. And I would say the time for transformation is now. Thank you.
Thank you. Thank you very much for your very elaborate comments related to the experience you've had implementing this in South Africa, from the funding side of things, where you're overseeing multiple partners that are doing the work out there. We'll have comments from the last panelist, and our last panelist is Professor Abimiku. Professor, over to you for your comments.
Thanks very much, Francis, and thank you all for the opportunity to listen to this presentation and join in this discussion that SLM has very efficiently brought together. I will speak from the aspect of an implementing partner that has worked in several countries. So the Institute of Human Virology in Nigeria with the University of Maryland in Baltimore have implemented PEPFAR in a number of countries. And I think what Tim has presented today in terms of the ability of SID to really introduce the current state of the art, which is the digital technology. How can it improve a lot of the things that we have been struggling with? And one of the key building blocks for ASLM as a Pan-African society to make sure that laboratory services are of such high quality that it actually promotes healthy living and in fact save life, is the fact of quality. And how can we maintain this quality so that the laboratory tests are always dependable by those who require it, and also that it saves life. So in the presentation today, as my fellow panelists has shared, I see real advantage in maybe three key areas. One is the fact that this application, referred to as RT-CQI plus, gives us the ability and the tool to be able to take some of our services closer to the clientele, to the patient, without worrying too much about the sophistication required and the quality. So this really, when you take into consideration that we're looking at, for instance, as the example given, whether it's rapid diagnostic tests as far as HIV is concerned, or TB or SARS-CoV-2 or any pathogen. Here we have the ability to take the testing closer to the client, but ensuring that quality is maintained. And I think that that is a really strong aspect of this tool, that it also uses app, which is very simple in terms of helping the field worker or even the physician, that is involved in those testing. So I think that that is one huge advantage of the app, that it takes it closer to the patient and is allowing us to deliver laboratory tests of quality. The second aspect of it is the fact that it takes into recognition not only the full circle that should be considered when you're looking at quality, and the SPI-RT talks about 7 different models. So it's very comprehensive in nature. It starts with the pre-analytic and post-analytic, and in that aspect, it is really wholesome. The third aspect of it is the capacity building, as I see it, and it's capacity building for everybody. Is for the field operators that could be within the countries and going out and ensuring that tests are done right, with the managers that could be in the country and also ensuring all of that, making it really possible to be able to monitor several sites, which would have been impossible, especially as we move closer to the clientele. So in bringing together this different groups, providing an ability for them to be empowered and their capacity built to deal with whichever aspect of it, I think is very comprehensive in that nature. And then putting again for me that aspect of training and building capacity clearly shows that SID is not in the business of just creating business for themselves, but is in the business of building the capacity in country and ensuring that the authorities, the government in the countries and the facilities have the ability to see the effect of everything that they are doing digitally. So using the digital and then finally, the comment that I'll make is really this very innovative partnership that SID has presented as a model, where SID expertise is now limited to the area that they provide advice and expertise in the areas that the specific countries need that expertise. So I really think that they've done this very effectively in terms of building your capacity to where you're comfortable in terms of doing this work, but they are also in the background being able to bring forward the 17 years or 20 years or how many years of experience they've had to work with various countries. So it's really great partnership. And because of their neutrality, they're able to share all of the information with the facilities, with the government, with the donors. So it's very transparent. And for ASLM, I think that this is a tool that would allow ASLM to do what it does very effectively, which is improve the quality of what we do in the laboratory across the continent very effectively. So on that note, I will thank you for the opportunity to share some of my thoughts. And thanks a lot for a wonderful webinar.
Thank you very much, Professor Bimiko, and very wise words, concrete from the experience that you've had dealing with both the platform, but also the RT-CQI that we know has been with us, I think, from about 2016. Now, with this, we will go to quick questions that have come through, and thank you very much, Lehman. I think Lehman works with team, and you've dealt with most of the questions, but we'll still run through a few and make sure that clarity is provided to everyone. Not everyone might have been looking at the chat. The first question is coming in from Moses, and Moses is asking, I'm combining two questions from Moses. What equipment do we need when we are supposed to deploy this? And also, as part of the equipment, do we need a standalone server, or we can rent spaces in the already existing servers to be able to run this innovation? Tim, over to you.
Thanks very much, Moses. Thanks for those questions. So we have designed this to be as simple and user-friendly as possible. So with regard to the equipment needed, each staff member that we have has either a simple smartphone or a simple tablet. It can also be, duplicated on both of those, and a laptop. But in that setting, it really needs a tablet, not an expensive tablet, a relatively cheap tablet onto which everything is loaded, so that they are set up by us prior to them being shipped out. And those tablets, it's better if they can have some 3G capability, so that you can get direct communication with your manager when you're on site. And then the persons go into the field. So what we've done is we've taken away all the paper and the logbooks and all of that kind of thing. The apps are able to take a photograph of what you see on site, so that if you see something that you want to document, you can take a photograph of it, and you can. So it is a simple system based on a tablet or simple smartphone that people need. And then when that data is uploaded, we can work with our business analytics team to ensure that the most efficient system is in place. But there is already, this is all, like so much in the world, everything then goes up into the cloud, into a secure environment. Remember, none of this is patient level data, it's about procedural data. And what we then have is we then have a server which has, where our business analytics team work on these matters, and then they would give you those results. If there was some need for some mirroring or something like that, I'm sure that those discussions can happen, but I'm sure that Lamont and Amanda and Peter are going to be saying that they need to answer that question rather than me about what is technically possible on server space and on where these things are placed. But it's about a discussion with you, Moses, and you, your organization, your Ministry of Health want to engage. We'd be delighted to engage, and I think there will be differences country to country, and we will make sure that we are able to serve each country's needs as best we can.
Thank you very much, Tim. I have the next set of questions coming in. I'm combining Pascal, Joseph, and Pascal and Joseph. They're asking if this system can work offline. You just can elaborate on that. And a gentleman called Thank God, a gentleman or a lady, and I'm sure he's also saying the same, but hers is a bit different. Auto synchronization. So if data is captured offline, does it get auto synchronized when you get to a place where there is internet access, or do you have to then upload manually?
Thanks for those questions. The offline capabilities of this are central, and I think in Africa, as we increase our spread of the digital age, where we have internet connectivity is spreading. We in South Africa are no different to anywhere else on the continent. Some places we have excellent internet connectivity and some places not. So it has to be entirely functioning offline or online. If you are in a clinic where you're able to log in and you have internet access, it will upload as you put the data in, and you can interact with your manager on a real-time basis. But if you are in a remote environment or a not so remote environment that you don't have access to the internet, your entire set of evaluation modules, your videos, your capacitation, all of those things are preloaded on your smartphone or tablet. And therefore you would go in, you would document what you're seeing, you document what you're doing, you document who you trained and all of that. And when you finish, you would then close your app down. And when you drove back, either at the office, it would auto-upload, or when you got into 3G connectivity and you had data on your tablet, it would auto-upload. So it's a very simple means of doing that. And then when it's uploaded, your manager sees it because it comes up on that ticker, and your manager can then see where you've been and what you did. I'm not sure if there are opportunities for our team also to answer if I missed out anything. I'm not sure if they want to add anything on. So our system was built on a system called COBA. And COBA is a great system which is available. And what we've done is we've worked with COBA Connect. And we've taken that and then worked with it, modified it, and ensured that it is applicable to what we're doing here.
Thank you, Tim. There is a quick question that has just popped up. And somebody is asking if you have submitted your data, is there a provision for you to retrieve and make corrections, or once submitted, that's it?
No, you can. So part of what we do is we get our people into the field and they load their data up, or they perform the intervention and the evaluation, and that then uploads so that your manager can have a real-time assessment of where you are and what you're doing. But in addition to that, you have the ability when you get back into the office to log in on maybe something that's a little easier to access, your laptop, or and then you're able to open up your report, maybe add some more text to it, maybe add a little bit more that you found out on the way home when somebody called you about that problem. So you can add to it so that it is enriched, and then the quality improvement plan that comes out of that is better as well.
Okay, thank you so much. Let's move it on to the last question. We have many questions coming in the chat room, but also thank you, Lehman. Please continue answering some of the questions that are just arriving in the chat room. The last question is coming in from
There are two people there who are answering. I see Lamont and Amanda, the Executive Director for Lab Services, and I think Peter was answering a couple as well. So the team in the background is answering actively.
Okay, thank you. So, Tim, my last question to you is on certification. And this is coming in from Leonardo, and he's wondering, once somebody has completed the training, is that adequate for them to get a certification? And is this automatic, or they have to then wait for some processing from the management team before then they can get certification or recertification, depending?
So the content is certifiable. What differs from country to country is the concept of what national certification means. And in some countries, that will have a stamp of approval from your national Ministry of Health. And we have a situation where it is a stamp of approval at the provincial level. So there's an example of where it can differ from country to country. But what is important is that if we were to collaborate, we would need to work out what each country, Malawi, Tanzania, Kenya, etc., defined as national certification, and then we would then comply with that, so that if it was a Luapula province that needed to stamp it off as opposed to central government, then we would ensure that they approved the certification process and the certificate came out in that name. So I don't want to be, my point here is that every country would need to define it, and then the content that we have would be standardized and appropriate for that.
Thank you very much, team and colleagues. We've reached the top of the hour. We'll just extend it by about a minute to do the wrap up. Team, we'll also get back to you to get us your experience in deploying this tool, both directly and also deploying it through implementing mechanisms, like a sort of above site deployment, not going directly to sites. So handing it over to implementing partners and then they do the deployment versus deploying it directly, and how that plays out. But we will get back to you on that. Not in this session where we've run low on time. Colleagues who are online.
That's exactly what we can do. Okay, so we can come back to that. We can do that and deploy all the people who are in the field already to do this.
Okay, thank you, team. So colleagues, we've reached the end, and as usual, we will have the slides shared on our online resource center and other social media platforms. You can access your certificate using the code available here. I know that a few sessions back, we had some glitches with accessing certificates. Please go there and let us know if you're still struggling, but you should be able to access your certificates using the code available on the screen right now. We also have a lab culture document that was released, version 27. Please look it up in our resource center and download. There is a wealth of information that can support you as an individual, but also the entities from which you come to support the strengthening of lab work and other aspects of care that you do. Until our next session, from me and the ASLM team and from our presenters, we wish you the best of the remaining day ahead of you, and thank you very much for making time to be part of this very great session. Thank you, and over.